Good morning, and thanks for joining us today. I'm Dr. Kelly Ferraro here with Denver Health Palliative Medicine. And I'm joined by two of my colleagues, Meg Lands, our oncology and palliative social worker, and Chaplain Rebecca Scull, who also works with our patients. We're here to talk about total pain, using your entire interdisciplinary team to make sure you're providing full patient care. As we start, I'd like to ask you to think about what's the hardest thing in treating a patient's pain? What patient comes to mind for you, and what was really tough about it? Think about that patient as we go through and talk about total pain. So today we're going to talk about a patient case. We'll talk about evaluating physical pain and then total pain and the role of chaplain and a role of our social worker in both evaluating and treating total pain. Then we'll come back and let you know about our patient at the finish. So our patient is a 38-year-old woman diagnosed with breast cancer, metastatic to her lungs and vertebral spine. She drives straight to our hospital in pain from New Mexico with her mom, and they say, help. Her mom says, help her. And every time we would meet her, she's clearly in distress. So I want to start with the traditional pain assessment. This is what I was taught in medical school, PQRST, thinking about the palliative and provocative factors of the pain, the quality, where it is, what does it feel like, radiation, severity, and timing. You're all probably very familiar with the Baker-Wong or Wong-Baker FACES pain rating scale here to the right, thinking about no pain to the worst possible pain and asking our patients to rate their pain on a scale from 0 to 10. What we've come to realize is that this encompasses just one facet of pain, and we're really missing major components. So remember that understanding total pain is a prerequisite for pain control and for getting good pain control in our patients. The term total pain was coined by Dame Cecily Sanders, the founder of hospice, and now as we move upstream, the palliative movement. And much of our total pain experience is composed of a mental reaction, said Dame Sanders. Think about that. The suffering, total pain is the suffering that encompasses all of a person's physical, psychological, social, spiritual, and practical struggles. If we're not addressing all these components of pain, we're not going to have good pain control. When I think about total pain, I think about 4 domains. Think about a physical domain, and that is what's covered by the PQRST, 0 to 10. Think about pain that's caused by cancer or caused by treatment, an underlying disease, or comorbid causes. But it's also so important to think about the psychological realms of suffering, things like anxiety, depression, what was their past experience with illness, potentially even a family member's past experience with illness, their fear of suffering. They may not currently have active suffering, but they may be thinking about something they'd seen and be worried it's in their future. I think about a social realm for total pain. Did they lose their job? Are they worried about keeping their apartment? Do they worry about the future of their family or being dependent on others? And then the loss of their role in social status. Many of our patients will say, I'm a worker, but they're no longer able to work. What does that mean to them as a person? And then the spiritual realm of pain. Are they angry at God for what's happening to them? Do they have a loss of faith? Are they having difficulty finding meaning or fear of what's unknown in the future? These are all realms of suffering and total pain, and it's important to engage with our entire team. So for our patient, I went through PQRST. She had pain in her breast where she had breast cancer. There was clearly physical pain there. She had a fungating breast mass. Her arm was very swollen with a clot. At the same time, she also expressed she's the mom of 3 young boys. She'd been away from her family for 2 years, experiencing significant physical and emotional trauma. She and her family are devout Christians, and they wondered, why is God punishing us so much? So as the physician, my role is really to use the correct medications to treat the physical pain and to also then recognize total pain. I can help with that, but I recognize that I am not the expert in these other realms. And so calling the interdisciplinary team is critical to our success.
Hi, my name is Meg, and I am currently an oncology social worker. Previous to that, I worked in hospice and palliative care for 13 years. My interest in these three areas came about because of my experience with my mother and our family's journey with cancer. She enrolled with home hospice in the early 80s. Our experience with hospice made a big impression on me, and I knew that I would want to one day work in the area of end of life. Even though it was mostly a positive experience, there were two things that would have made it better. We had no social worker or chaplain. I often wonder what kind of experience it would have been if we did. My mother was deeply religious, and there was no one there to support her spiritually, as we had moved her from Illinois, where her church was, to Colorado. And I, as a young adult, was barely out of an extremely rebellious adolescence. We never talked about it or our relationship. My mother was angry at her illness and often took it out on my brother and I, her caregivers. I wonder how it would have been different if we had someone to initiate and guide conversations about these things. So part of what I feel is important in providing support for our cancer patients and palliative care patients is informed by my experience. And part is also informed by our patients in Denver Health who often lack the basic necessities to get through life. It is even more important that they have these resources when they have a serious or terminal illness. Depending on the wishes, needs, and goals of the patient, I feel that the following are some of the most important areas to broach. Next slide. So these four areas is something that I try to go over with the patient: securing basic needs, housing, food, income, transportation, and other various resources, planning for the future care needs, future care wishes, acceptance, finding meaning in the illness and change of role, life review, managing depression, processing guilt, anticipatory grief, etc. Repairing or strengthening relationships with significant others, family members, friends, and children. Part of a social worker's role includes getting patients the resources they need so that the patient can live as comfortably and stress-free as possible, physically, mentally, and emotionally. At Denver Health, often our patients are struggling to get their basic needs met. We work with the working poor, the homeless, the uninsured, and the undocumented. Some of our patients have low health literacy or are illiterate altogether. Next slide. Chrissy's situation was not unique from a lot of the patients that we see at Denver Health. She and her family were drowning financially. Often the most urgent need is helping with basic living expenses, food, housing, etc. And one of the hardest things for our patients is not feeling well enough to work. Not only is the patient grappling with a lost sense of self and fears about treatment, pain, death, but also still has to worry about all the things that were on their list the day before the diagnosis. Very often when I ask patients what they are most afraid of, they say they are most worried about how they are going to pay their bills or buy food and other necessities for their families. Next slide. So there are resources that we can offer, each dependent on the patient's diagnosis, working history, family composition, and legal status. With the diagnosis, there are grants from Cancer Foundation specific to the type of cancer. There's a couple that do grant money for any kind of cancer, but most of them are specific to the cancer. And then there's other organizations that offer various types of help for other illnesses like ALS or Alzheimer's. Their working history and legal status determines eligibility for Social Security, disability, Social Security, retirement benefits, utility help, and some cancer grants. The legal status, criminal history, and credit score can determine eligibility for housing and utility help. Ages of the children in the household can determine what kind of help is available. Age of the patient can determine housing and qualifications for other resources like transportation. Insurance can drive treatment, transportation options, and whether they can get unskilled help at home. And housing can determine what treatment a patient can endure. Next slide. Chrissy had at least 7 social workers and case managers helping her and her mother initially with resources. That included getting help at home, food stamps and meal delivery, transportation, housing, including rental assistance and other grants, Social Security disability, benefits for the children, discharge planning from the hospital and honoring her wishes around this, advanced care planning, emotional support for her, her mother, children, and family. And our chaplain was very involved with her family. One of the oncology nurses took up a collection at Christmas from the oncology and palliative care teams to get the family a sizable gift card that they could use for food and other necessities. She was further supported once she enrolled with hospice. As you can see, she was not only helped by the doctors with her pain, but also from numerous other disciplines. Next slide. Another area that I ask about is if they will consider planning for the future. Does the patient live alone? If so, how will they manage if and when they can't take care of themselves? Do they have family? What is most important for them to do so that they can worry less about their family if they are no longer around? Have they thought about and placed in writing what their healthcare wishes are should they not be able to speak for themselves? It still haunts me decades later what my mother went through. None of us questioned or knew that some of the things that she went through were optional, including going back to the hospital. Next slide. Other things that social workers help with are helping people process their emotional experiences of having the illness, their grief, fear, sadness, depression, guilt. Sometimes they feel that they caused their illness or have guilt from other areas of their lives. Changes in their role and identity, acceptance, helping them to find meaning in the illness, life review, recording a legacy, and something that I feel is most important, help repairing relationships. Next slide. This area, repairing relationships, I feel is important with working with my patients. Social work is all about systems, and relationships and families are systems. There is much research about the importance of quality relationships and how they affect health and longevity. There is also research about how conflicted relationships can equal complicated grief after the patient passes away. And above in this slide, there is just a few quotes about health, relationships, and longevity. Next slide. Often the patient and the significant other or the caregiver are each suffering alone. Over and over, we hear patients and their caregivers say that they won't share their feelings because they don't want to upset the other one. So they turn inward to be strong in order to protect the other one. But then they lose the opportunity to increase their emotional connection at a time when they need it the most. This slide doesn't just apply to significant others. It can be a mother, like in Chrissy's case, or a child taking care of a patient, or a parent, etc. Things can continue to go unsaid, like in the case of my mother and myself. Next slide. Secure attachment is something that we need throughout our lifespans, not just when we're babies or children. It can mean that the patient realizes that the caregiver might be overwhelmed when they forget to do something versus that they just don't care. because they have a secure base in that relationship and they trust the other person. If the patient starts to withdraw, the caregiver can see it as part of the illness process rather than a rejection of them. The caregiver also needs to know that they matter to the patient. And again, this can apply to any patient-caregiver relationship. If they each have a secure attachment, the distress can be significantly lessened, as well as the grief process. Next slide. How does this apply to nurses? As nurses, you can spend the most time with patients. In my experience, you are great at identifying when there are transportation and financial barriers, and in identifying when patients are open to doing advanced directives. I invite you to also listen for indications of relationship distress and refer the patient and partner and family to a qualified social worker or therapist who works in emotionally focused therapy with couples and families. And I did put a website up there, a link where you can locate somebody who works in that. Sometimes you don't have to listen very hard. The couple or family will be displaying the conflict when you meet with them. But usually the conflict is a maladaptive way of wanting to be closer. And the benefits of a better relationship can be the best medicine of all, because it is the partner or the family or the caregiver who is there in the middle of the night to help ease the pain and fear. And changing their maladaptive cycle can alleviate years of suffering and misconception that the couple or family may have had about the relationship with the patient and with each other. Next slide. So this is a statement made by one of our Denver Health patients that I met with recently, who stated that he never knew how many people cared about him until he was diagnosed with cancer. It is not the medicine that takes away the pain or the cancer, it is love. Thanks so much for letting me be a part of this presentation.
My name is Rebecca, and I'm a chaplain here at Denver Health. I work with oncology and palliative care. And when I was asked to be a part of this presentation, specifically on this specific patient, I really felt that I needed to start by helping define what I view as spirituality, coming from my perspective and what I see, because I think spirituality and spiritual pain is often one of the most unrecognized pains, and it's also sometimes the hardest to define. And so I wanted to just start by letting you all know how I think about spirituality and spiritual pain. And so for me, spirituality really begins with what we all share, what we all have in common as human beings, regardless of our race, our religion, our background, our gender, our identity, wherever we're from. This is where we start, and this is where I start when I'm working with patients. And I start by just recognizing that we're all human, right? We're all on this planet together. We're all in this life together. Very different backgrounds, different experiences, but that's what we have in common. We all need to be loved and to be cared for, to feel accepted and to be respected. Those are all basic things that all of us are looking for and all of us need in our life. We're all looking for ways to cope with life, right? Every single one of us has things that happen, or has experiences that we're going through, has experienced emotional pain, physical pain, things, grief and loss in our life. And so we're all just simply looking for ways to cope with what we're doing at any given time. We're all looking for ways to feel connected with others. There have been numerous studies that have proven that as human beings, we are hardwired for connection. It's part of our DNA. It's part of who we are. We are relational creatures. And so those relationships and those connections that we have with other people are paramount when we talk about physical pain, when we talk about total pain, when we talk about coping, when we talk about treatment, how are we connected and how are we supported? And then the last assumption that I start with is that we all have a set of beliefs that influence our lives. Many of us have names to our set of beliefs. Some find those beliefs through religion or through spirituality, but regardless of where what we identify, we all have beliefs that influence our lives, that influence how we think about ourselves, how we think about the world around us, and how we think about our own experiences that we're in right now. So when I talk about my definition of spirituality, this is really where I start from. And so my understanding of spirituality is that spirituality is how we answer two questions. And they're really kind of questions of meaning and purpose. And those are, who am I and why am I here? So who am I? I just listed some types of questions. You know, what are the characteristics that make me who I am? What are the beliefs that I hold? How do I want other people to relate to me? And how do I want to relate to other people? And then why am I here? What are my hopes, my dreams? What gives my life meaning and purpose? What do I believe about the world? What do I want to be remembered for? That legacy question. And what is it that brings me joy? What is it that brings me peace? What is it that helps ground me in life? I apologize, I keep flipping the wrong direction. So building off of that assumption and my understanding of spirituality, when I go in to meet with a patient, this is a kind of a general assessment that I do. When I'm assessing for what are their spiritual needs, what is their pain, what are the questions that they're wrestling with, this is what I use. And I talk about, you know, what is their faith, what is their belief, how do they find meaning, right? What is it that they hold that's important, and how does that influence their life? They're talking about the importance, right? How important are these values? How important is their religion? Is their spirituality? Or just simply the values that they have in their life, and how does that influence not just their life, but their medical diagnosis or their cancer or whatever it is that they're going through? What is their community? Are they a part of a faith community? Do they have support from their family? Do they have a group of friends? What is their community, and how important is that in their life? How attached are they to that community? And then going from all of that, how can I help them? What are the actions that I can take? What are the specifics of how I can help support them as they're going through their medical diagnosis, through their cancer, through whatever it is that is going on with them? How can I take what is important to them and help them make meaning off of that? So in this particular case, what was my role? After I met with this patient and did the assessment, what were the specifics and the things that I learned? So one thing to know about this particular patient is that she was seen by our inpatient team. And so what I provided in an outpatient setting was a continuation of care, of spiritual care, from the inpatient to the outpatient setting. That piece right there is critical in the patients that we serve, to provide that continuity of care from the time that they discharge from the hospital through their enrollment in the outpatient setting and through their treatment in the clinic. I met with the patient, I met with Christy and her mom in the clinic, and also during chemo, I met with them in the infusion center, and I also spoke with them over the phone. I helped Chrissy and her mom understand how their Christian faith could help them as her health continued to decline. So really, you know, digging in and answering those questions of why, what is the meaning of suffering? How does that apply to our specific faith and to this pain that I'm experiencing, and these questions that I'm wrestling with? One of the things that I learned is that they both enjoyed reading devotional books. And so that was a very practical thing that I could do, is I could bring them a devotional book every month just to as a way for them to experience that practical aspect of their faith. I offered support around the strained family dynamics. It's really understanding that these relationships are important and that they're part of their support system, regardless of how strained they are, and just talking through some of those dynamics. Learning that how both the patient and her mom answered those questions of meaning and purpose. So our patient, what was important to her was being a mom. That was her sense of purpose. That was how she found meaning in her life, was through her relationship with her children. And on the same token, her mom found meaning and purpose in being a caregiver and taking care of her daughter and bringing her to chemo appointments and making sure she met her, was there for her telehealth appointments, and just in that physical aspect of taking care of her. I did grief work, right? Because grief is an important part. Grief and loss is an important part of a medical diagnosis, especially with a long-term disease like cancer. So we were able to do some grief work, just not only talking about this present situation, right, and all of the changes that go on with that, but also knowing that this mom had also lost another daughter. And so there was still some grief attached to that hadn't been worked through, and that was influencing how she was relating to her daughter and the struggle with cancer. I was able to provide both emotional and spiritual support, but I was also able to provide something that was really meaningful to this particular family, and that was prayer. And just walking through those emotions that come up and how they're dealing with this continued decline in health. After our patient died, she transferred to hospice, and after she passed away, I was also able to provide continued grief support to mom over the phone, which was another way that we continued that relationship that we had built inpatient in the hospital, continued into the clinic, and then continued on after her death. Meg mentioned that this was a case that really was impactful to our staff, and so much so that there was a nurse that took up a collection. And so another role that I have isn't just working with patients and families, but it's also providing care to staff. And in this particular case, this was a patient that really impacted our staff. And I think part of that was the complex nature of it, but some of it was her age, and she had young children, and staff is wrestling with their own total pain questions, right? Why does this happen? This patient was so young, they had their whole life ahead of them. What's going to happen to these kids? And so I was able to provide some grief counseling and some support to staff around how this case impacted them as well.
So finishing up with our case, our patient lived an additional 10 months after we met her. Her physical pain was controlled with morphine and oxycodone. And notably, she had prior issues with substance abuse, significant substance abuse, but she always took this as prescribed. It was a major worry to me. And I really credit our interdisciplinary team, social work and chaplaincy, with helping so much with her total pain that she could take her physical pain medication as prescribed. Our team social worker, Meg, and as she mentioned, many others were working on this case, helped arrange grants for her family, transportation, and housing. And Rebecca, as our team chaplain, supported the patient and her mom emotionally and spiritually as she transitioned from actively seeking treatment to hospice. She transitioned to hospice about a month before her death and died at home. She was at peace, and her family was present. They received additional bereavement support, as Rebecca mentioned, both from her in the pre-hospice team and then actually from the hospice team as well. And I hope that this case has shown, has really illustrated total pain. As you think back to that patient or those patients where you thought about difficulty with pain control, I hope you're maybe reflecting on, are there ways that we can address those other elements of pain, and seeing how emotionally this is really These are difficult patients. When patients have total pain, just like Chaplain Rebecca mentioned, just like Meg mentioned, this is something that the team feels. We're all in this because we want to take great care of people, and it can feel out of control. And so I hope you heard how we leaned on each other to really make sure that she got the best possible care and that we came out of this resilient and still feeling as though we can continue going on with working. Thank you very much for coming. We appreciate your time, and we're available online to take questions after this talk. Take care.